Good to go, sir. Okay. Hi, everyone. A very good evening to all the students. I hope I am audible and visible to all of you. If I'm audible and visible, please tell in the chat box. I have the chat box open in front of me, and so we can start with the session. I know your exams are just around the corner, and so I will not waste much of your time. So I will keep it crisp. I will keep it high yielding, and we will discuss not only 20 MCQs. I will also be making flowcharts and discussing past INI CET questions with you as well. So in about 1 hour, we are going to cover a lot of ground, and including the new topics and two new updates in Nelson and OP I will be covering here. Right. So thank you so much. Very good evening to all of you. So let us start with this session. We have called it as RDX series. It's a very high yielding topic discussion for INI CET. Uh, Yesterday we started with a mock exam of this on the DocTutorials app as well as on the DocTutorial website. I know that many of you have taken, and some of you might be listening to this discussion. So if you have taken the exam, this is the explanation of the questions which you encountered. And if you have missed somehow, or you are listening to this as well just now, please be rest assured that this next 1 hour is going to be very high yielding for all of you, and we will cover a lot of ground. And yes, it is relevant for the NEET PG exam as well. And of course, except for one or two topics, about I would say 90% things will be relevant for FMG exam as well. There are a few things which will be a bit on the higher side, higher difficulty level, but a few overlap topics. If you are FMG aspirant, you will definitely benefit. But our core area, the core focus is on INI CET exam aspirants as well as the NEET PG exam aspirants. So let us start with the discussion. First of all, let us look at question number 1. Which among the following is the height velocity in the first year of life? If you have seen the INI CET May 24 paper, there was one question asked on head circumference gain in the first year of life. Now, if you look at OP talks about two types of velocities at different parts, of course. It talks about head circumference velocity. The discussion and key points related to that topic I have already done in a recall video. The second thing which can be asked to you in the exam, which is a yet unasked question but relevant for your exam for INI CET and even for NEET PG exam, is what is the height velocity in the first year of life? So this question is asking which among the following is the height velocity in the first year of life? What is your answer? A, B, C, or D? Let us first understand what is the meaning of height velocity. So what does height velocity mean? Height velocity refers to increase in, it refers to, just a minute, it refers to rate of increase in height, rate of increase in height over time. And it is always mentioned as so much centimeter per year, right? So it is a fact based question, and we need to remember what are the key facts, what is mentioned in ghai. Some of the facts are mentioned in ghai, for others I am taking the help of Nelson. So for future exams, you need to remember that in the first year of life, the rate of height velocity or the rate of increase in height over time is 25 centimeter per year. It is 25 centimeter per year. Absolutely right. Most of you are answering it correctly. The answer is C, 25 centimeter per year. In the second year of life, it becomes 12.5 centimeter per year. Between 3 to 4 years, between 3 years, so in the third year as well as fourth year, it remains 7 centimeter every year. Between 4 to 9 years, it becomes 4 to 6 centimeter per year. And then once puberty comes, in the pubertal period, it becomes variable. Why variable? Because there will be, with the onset of puberty, there will be onset of increase in height velocity. We call it as growth spurt. And in bracket, you can write the general peak growth spurt, the maximum gain in height during this period will be varying between 8 to 12 centimeter per year. In case of girls, it will be from 8 to 9.5. And in case of boys, it will generally be ranging from 9.5 till 12 centimeter per year. So these are the values which are given in the OPGHI textbook, OPGHI 10th edition. These two values are mentioned at one place. Remaining values are mentioned at elsewhere places. If I am a INICET examiner and I have a tendency of asking rate of increase in weight, rate of increase in height, rate of increase in head circumference, this is one topic on which MCQ has not been asked. So not only for INICET, but for NEET PG future exam also, this fact, this point is important. Now, many of you might be thinking, ki, sir, how did we come to this conclusion? See, end of the day, these are facts. You are supposed to remember the facts, right? You are supposed to remember the fact. But if you remember, at birth in a normal child, the length is average 50 centimeters. And at 1 year, it becomes 75 centimeter. And at 2 years, it becomes 87.5 centimeters. So see here, what is the rate? What is the gain happening in the first year of life? The gain is 25 centimeter per year. And what is the gain happening between 1 to 2 year? It is 12.5 centimeter per year, and so on. So this is how we are actually taking the height velocity gain in the patient, right? So rate of increase in height over time. At what time adult height will be reached? It will be reached when there is fusion of the growth plate. Fusion of the growth plate is variable. It is variable according to the age of the patient. It is variable according to gender of the patient, and it also depends upon the family history. People with a people with who have a tendency to have late closure of the epiphyseal metaphyseal growth plate, they tend to continue to grow for a longer time. So examiner is not going to ask you that particular aspect. So question number 1, the answer is C. Apart from that, please add this particular thing which I have mentioned for in your notes, revise it. It will be useful for INICET, it will be useful for NEET PG as well. Let us go to question number 2. A child has recently learned to do walking as depicted in the image. What is the likely age of the child? What is the likely age of the child? Now, you have to understand, and this is based upon the new update in OPGHI. It is a new update in new OPGHI 10th edition. Hot topic, potential fresh MCQ for your exam. So what is this milestone called as? So if you see carefully, the elbows and knees of the child are not touching the ground. The child is walking on all four limbs. Both the palms and both the soles are touching the ground. This type of walking is not called as crawling or creeping. This type of walking in the child is called as bear walking. So this is a child who's showing bear walking. And bear walking in a child comes at what age? It is a fact-based question. Bear walking is a milestone. It comes at 12 months of age. Try to think, this is not creeping and crawling, this is bear walking, and it is a common mistake people are expected to make. If you get this question in the exam, see carefully, and I will show you in few minutes how to distinguish between these crawling, creeping, walking with support, etc. So first of all, please understand what is bear walking. How do bears walk? Bear walk on two palms and two soles, but their knees and elbows are not touching the ground, and intermittently they will be able to get up, they will be able to move or look around, and then again while walking they will be putting both the palms and soles on the ground. This type of walking in the child is called as bear walking, and bear walking comes at 12 months of age. It's a I could have just simply written it as a one liner, but the reason I have put this as an image based question is once you have seen the image, you never forget. Now let us do a quick revision. What are the 5 important gross motor milestones which people get wrong? Milestone, high yielding topic. It is a rank decider in INICET as well as NEET PG exam. Look at the first thing. This child, whenever the child uses all four limbs to move, and knees and elbows are touching the ground, as well as the abdomen is touching the ground, we call it as crawling. So in a patient of crawling, how to identify crawling? Knees, elbow, as well as the tummy, that is the abdomen, all of them are touching the ground. Now look at the image. If they give you a photograph, if the child is walking and all the things are touching the ground, we call it as crawling comes at what age? It begins at about 8 months of age according to Nelson. So this is a patient who's doing crawling. Look at the second image. When the child walks, but the abdomen is lifted off the ground, That is called as creeping in the patient. So look at this milestone as shown in the image. This is creeping. In creeping, it will be similar to crawling, but the abdomen is off the ground. Abdomen is off the ground, but in bracket you would write knees or elbows or both will be touching the ground. I'm writing it like this because if I tell you now, you will understand it. But if you don't revise it again, you will miss it. I want you to listen to the words. This is not how it is written in OP but this is the way you are supposed to remember. Milestones, you try to remember them as tables or as mnemonic, you will always forget them. If you try to make generalization, solve some MCQs, and then form some rational comparisons, it will be easier for you to remember. So this is creeping, and creeping comes at 10 months of age. So creeping comes at 10 months of age. Look at the third milestone. Can you see that this child is putting all the palms and soles on the ground, and she is walking like this? Abdomen is off the ground and knees and elbows are not touching the ground. This is what you call as beer walking. So this is a child who's showing beer walking, and beer walking comes at what age? Beer walking comes at 12 months of age. Look at this fourth milestone. Examiner will say there is a child who's walking, who's taking the help of edge of the furniture and then moving from one place to another. This is what you call as cruising, also called as cruising along a furniture, which comes at 11 months of age. So whenever there is a child who moves along the edge of a furniture, that is called as cruising along a furniture. And look at the fifth milestone. Now this is a child walking, but she is walking with support. So this is called as walking with support. If they show this image, walking with support comes at 12 months of age. Absolutely right. Walking with support comes at 12 months of age. So 5 milestones, image can be asked. They can be a part of a question. They can be part of one-liner. Crawling, creeping, beer walking, cruising, walking with support. Out of them, beer walking is the relatively new milestone. It has already been there, but it is just that the examiners are now mentioning it, and the textbook people are now mentioning it in the text, right? So question number 2, the answer is D, 12 months. Let us go to question number 3. Now, this question has been made based upon how multiple choice questions are asked in INI CET. And this question, there is a reason I have put it up. It is a tough question. The reason for putting it is because if you look at INI CET May 24, there was a question asked on indication of cannabidiol, right? Cannabidiol in pediatric refractory epilepsies. There was a question on that. This is a topic which has been taken from Nelson 22nd edition. Examiners are putting questions from Nelson. They are not asking you the usual anti-epileptic drugs in epilepsies. They are asking you the drugs used in refractory epilepsy. And there are two important drugs, cannabidiol and one is ketogenic diet. It is not a drug by itself, but it is a type of therapy. Cannabidiol already asked in May 24. The only thing which can be asked again or for NEET PG exam is role of ketogenic diet in seizures. So let us do a quick revision. First of all, have a look at the question. A child with refractory epilepsy planned to be started on ketogenic diet. Which among the following is or are indications to use if the patient is not controlled? And they have given this set of questions. Now, let us do a quick review. Ketogenic diet. What is ketogenic diet? As the name is saying, a diet which generates ketone bodies, right? A diet which generates ketone bodies. So it is a type of therapy. It is a type of dietary therapy. It is a type of dietary therapy which increases ketone body formation in the body, which is found to have usefulness in management of refractory epilepsies. What are refractory epilepsies? Any epilepsy which is, or any seizure which is not responding to two or more frontline drugs of different classes, that is called as a refractory epilepsy or a refractory seizure. So it is a type of dietary therapy which generates ketone bodies, and these ketone bodies have a anti-seizure mechanism in the brain. Now, how do these, what is this diet? This is a diet. There are many variations of this diet. In this diet, in this diet, the fat content is found to be high. The fat to non-fat caloric content, caloric content, caloric ratio is between 3:1 to 4:1. So majority of calories in the diet are obtained from fat, and very few calories are obtained from carbohydrates and proteins. This type of diet is called as ketogenic diet. Now, what is the mechanism how ketogenic diet acts? The exact mechanism of ketogenic diet is unknown. Exact mechanism is unknown, but there are many theories how ketogenic diet acts. All theories they are proposed, but the exact evidence for this that is lacking. From exam perspective, you can remember that they act at multiple levels. They alter brain metabolism. When you give a ketogenic diet, the brain starts utilizing ketone bodies, and it has been shown that when brain utilizes ketone body, the overactivity in the brain tends to get suppressed. So altered brain metabolism. Secondly, they alter mitochondrial metabolism. Mitochondrial metabolism is also altered in these patients. Thirdly, there is increase in the GABA activity. I hope you know that there are two types of neurotransmitters in the brain. You have excitatory and you have inhibitory. So it is the inhibitory neurotransmitter mechanism which is activated by ketogenic diet. And fourth, they increase in glutathione activity in the CNS. You know that glutathione has a antioxidant mechanism, and so it has a neuroprotective action and reduces the chances of seizures provoked by various types of stress in the brain. So these are the four mechanisms through which it acts. The evidence is there, but the evidence level of evidence is not very robust. Now the question arises, what are the indications, what are the conditions in which ketogenic diet can be used? Ketogenic diet can be used in conditions like, first of all, Rett syndrome. It does not affect Rett syndrome per se, but the seizures in Rett syndrome can be controlled by ketogenic diet. Secondly, it is useful in West syndrome, also called as infantile spasm. In infantile spasm, remember, it is the third line therapy. When ACTH and vigabatrin fail, what is the next step in management? Examiner can ask you a question like this. So you can write in bracket, when ACTH and vigabatrin fail, what is the next agent to be tried? You have to give a trial of ketogenic diet. This is the third line therapy in the patient. Then it is also useful in patients with tuberous sclerosis, then there are seizures occurring in GLUT1, the glucose transporter 1 deficiency. It is important, it is used. Then we have a syndrome called as Dravet syndrome, which is also called as severe myoclonic epilepsy of infancy. Severe myoclonic epilepsy of infancy. I can explain all of them in a more calm manner. The only issue is your exams are around the corner and it is a quick rapid fire review that we are doing. At the same time, I'm not letting go of any useful point which I feel might be asked in the exam. And last but not the least, there is a syndrome called as Landau-Kleffner syndrome. Landau-Kleffner syndrome, right? It is also written as LKS. These are the indications where ketogenic diet is recommended in case first two anti-epileptics fail. There is a concept also here. If examiner asks you what is a refractory seizure or refractory epilepsy, generally in pediatrics, in case two different classes of anti-epileptics have been tried and seizures are not controlled, we call it as refractory. So in these patients and these indications, you can give a trial of ketogenic diet. With this in mind, let us go to the question and look at the question and give me the answer. A child with refractory epilepsy plan to start on ketogenic diet. Which among the following is or are indications to use this anti-epileptic therapy? So Rett syndrome is an indication. Dravet syndrome is an indication. Infantile spasm is an indication. What are we left with? Rolandic epilepsy is not an indication. And so answer to this question is A, 1, 2, and 4. What is Rolandic epilepsy? Rolandic epilepsy is a benign epilepsy. It is a benign epilepsy which tends to occur in 2 to 10 years, more commonly in boys compared to girls. And these patients show excellent response to drugs like carbamazepine as well as oxcarbazepine. And because it is a benign epilepsy, usually monotherapy with either of these two agents is successful. So that is why Rolandic epilepsy is not a part of this answer, right? not a part of this answer. So on question number 3, the answer is A, 1, 2, and 4. And this point which I have mentioned here, this by itself is also a potential MCQ one-liner. Mark it, add it somewhere. Save this video, uh, recommend it to your friends and juniors, and ask them to write all the additional points that we are writing, because yes, the video has been made with keeping INI CET, the upcoming INI CET in mind, but it will be useful for NEET PG also, and it will be useful for your future INI CET as well. But make it a point that you don't need to give future INI CET, right? Question number 4. A neonate was delivered at 37 weeks via normal vaginal delivery in a mother with preeclampsia, but the baby did not cry or breathe at birth. Baby was kept under radiant warmer, dried, airway suction, positioned, and stimulation performed. Evaluation revealed a heart rate of 30 per minute with apnea. What is the immediate next step in management? So basically, just try to see what has happened in the child. This is a newborn who has been born, and newborn has not cried at birth, right? Newborn has not cried at birth. So what has been done? Initial steps have been performed. Initial steps have been done. What are the initial steps? I'm marking them. You can have a look here. Putting under radiant warmer, drying, airway suctioning, positioning, and stimulation being performed. They are all called as initial steps in the patient. So they are called as initial step. After initial step, the next thing you do is check whether the patient is having apnea or gasping efforts or heart rate less than 100 per minute or not. If it is present, you will start with positive pressure ventilation. You will start with positive pressure ventilation. And because it is a baby above 35 weeks, above 35 week, you don't need to give oxygen. In a baby delivered at or beyond 35 weeks, you start PPV using bag and mask ventilation on room air. Now look at the option. Which option is telling you the answer? The answer to this question is B, use PPV on room air. Also look at the other options. Even if you are not sure about option number B, you can still apply some logic, provided you have understood the topic well. I always teach this topic in full details in my offline as well as online classes, and in my DocTutorials recorded lectures also. I have discussed in a very proper way the way you are supposed to remember. In case you have forgotten or not revised, you are always most welcome to revise it again. So once tactile stimulation has been done, it will not be repeated, so A will not be the answer. Child is not breathing, so only a person not breathing, you give 100% oxygen. What is the point? So C will not be the answer. And if the person is not breathing, first giving epinephrine and then starting PPV makes no sense. You first need to tackle the breathing part. Only when the breathing part is not effective and bradycardia is persisting, you go for chest compression, and only then you start epinephrine in the patient. So D option is not the answer. The answer to this question is B, use PPV on room air. So this is the NRP 8th edition. This is where the child is lying. If there is the child did not breathe or cry at birth, look at this, I'm marking it here. If the child does not breathe or cry at birth, the child first initial steps need to be done. Initial steps already performed. Check for apnea or gasping. This child is having apnea and heart rate is below 100. Then you will start with positive pressure ventilation. Many people might be thinking, sir, if heart rate is less than 60, shouldn't we intubating? Heart rate less than 60 is relevant only when you have given PPV. So remember, always the sequence to be followed in exam is always like this. In a newborn resuscitation, I'm writing on the side, initial steps are done, then you go for PPV, then you go for intubation. When you intubate the patient, you also give chest compression, and only then you go for epinephrine. And after giving epinephrine, you come back and give positive pressure ventilation and chest compression, right? This is the sequence you're supposed to follow. You cannot jump these steps. Remember, you cannot jump these steps. So yes, absolutely right. So question number 5. Let's come to question number 5. Question number 5 is based upon IMNCI guidelines, and similar question has been asked consistently in both NEET PG and INI CET exam. And for those who are FMG aspirants, this question is relevant for you also. Till you keep giving exam, trust me, even super specialty pediatrics, this type of question keeps getting asked, and still people keep making mistakes. So we'll do a very rapid fire review of this topic here. So look at question number 5 and give me the answer. I'm waiting for your answers. A 3-year-old child is brought to local hospital with complaints of fever and cough. On evaluation, child has this, heart rate is this, respiratory rate is here, subcostal recessions are there, Child is lethargic. SpO2 was 85% but improved to 99% on minimal oxygen. What is the next step in management? What is the next step in management? What is the answer you will give? What is the answer you would like to give? See carefully and give me the answer. A, B, C, or D? A, B, C, or D? What is your answer? Okay, some of you are answering correctly, some of you are answering it wrongly. Oh, a lot of you are answering correctly. This is a patient who's having severe pneumonia. So the patient is suffering from severe pneumonia because not one, two danger signs are present. Lethargy is a danger sign, abnormally sleepy or difficult to awake, and this patient also has hypoxia on room air. So severe pneumonia, you will give ampicillin and gentamicin and refer to higher center. Let us do a quick review of IMNCI guidelines. They say, in any child age less than 5 years who presents to you with fever or respiratory symptom like cough, first you define fast breathing. सबसे पहले fast breathing you will define. How do you define fast breathing? If age of the patient is less than 2 months, tachypnea will be respiratory rate equal to or more than 60 per minute. 2 to 12 months, it will be equal to or more than 40 per minute. And 1 to 5 years, it will be equal to or more than 50 per minute, and equal 1 to 5 year, it will be equal to or more than 40 per minute. Equal to or more than 40 per minute. So 60, 50, 40 is the cutoff here, right? Then you will see if chest retractions are present or not. They can be subcostal or intercostal. And then you will look for general danger signs. There are 4 general danger signs you need to know. If presence of convulsions, that is seizures, is a danger sign. Presence of severe undernutrition, also called as severe malnutrition, is a danger sign. If the child is having lethargy, that is a danger sign. What is lethargy? Abnormally sleepy or difficult to awake. Abnormally sleepy or difficult to awake. When I take classes, I see people, even in the first 10 minutes, they are sleeping off. So that is lethargy. And have you ever noticed that you always have a friend whose alarm is ringing and you are in the adjacent room, he is not getting up, and then you have to knock at his door and ask him to please shut your alarm clock. So that person, again, when you think of that person, he or she is having lethargy. So lethargy is abnormally sleepy, difficult to wake. Sometimes examiner uses the word lethargy, sometimes examiner uses the phrase abnormally sleepy, difficult to awake. They mean the same thing. And fourth, if the patient is having inability to feed or drink. Inability to feed or drink, right? So we do step by step. Check for fast breathing, check for retractions, and check for danger sign. And then you make the diagnosis. How you make the diagnosis? This is the IMNCI protocol. If there is no, start from the bottom, no signs of pneumonia or no sign of very severe disease, no pneumonia, it is likely a viral infection, so no antibiotics will be needed. In case patient is having fast breathing, that is tachypnea or chest indrawing, either of them or even both of them are present, but no danger sign, you will call it as pneumonia. You will use oral antibiotics. Which oral antibiotic? Amoxicillin is given for 5 days, and every patient needs to be followed up after 2 days. And in case patient is having any general danger sign or stridor at rest or SpO2 below 90%, which this child is, you will call it as severe pneumonia, also called as very severe disease. IV antibiotics will be needed. But you can't manage these children at PHC. You give first dose and refer to higher center. If you are already sitting in a higher center, you don't refer, you admit the child and start ampicillin and gentamicin. And while the child is being transferred, always give oxygen. Make sure that oxygen is being given. Have you seen those ambulances which are a sham, which have ambulance written Maruti Omni, but inside there is nothing? So don't fall for that trap. You are a medical officer, you are a qualified MBBS doctor. Make sure when the child is being referred, there is a working oxygen and somebody able to give oxygen during transport to the child, right? And the cylinder is also working. There are small little things, practical things you will not find in the books. And look at the color coding. Sometimes examiner asks you color coding. No pneumonia, green code. Pneumonia, yellow code. And severe pneumonia, also called as very severe disease, pink code. There is no such thing as red code or red label, right? So let us move further. So going back to the question, this is a patient. Have a look here. Patient has chest retractions. Patient has no tachypnea. So chest retraction, but patient also has 2 danger signs. So this is a patient with severe pneumonia, and you will give an IV antibiotic and refer to higher center. Question number 6. Which of the following is correct comparing breast milk with cow's milk? Which of the following is correct comparing breast milk with cow's milk? What is your answer? Give me the answer. A, B, C, or D. Srijita Basu, chest indrawing is not a danger sign. What is it written here? Is chest indrawing a danger sign? I'm writing it here in capitals. This is a mistake many of you make because you follow old guidelines. Chest indrawing is not a danger sign. All it indicates is that there is pneumonia in the child. It does not tell severe pneumonia, right? So question number 6. Which of the following is correct regard comparing breast milk with cow's milk? Breast milk contains less DHA. It is wrong. Breast milk is in fact contains DHA. Breast milk contains more protein. Wrong. It contains less protein. Breast milk contains less calcium is a correct statement. Contains more casein. Wrong. It contains more whey protein. So answer to question number 6 is C. Let us do a quick rapid fire review comparing. I'm writing on the side breast milk, also called as human milk. On the other side, you have animal milk, also called as cow's milk. So if examiner asks you carbohydrate content, if examiner asks you carbohydrate content, that is lactose. So lactose is more in breast milk, less in animal milk. If examiner asks you fat content, it is less in breast milk, more in animal milk. If the examiner asks you protein content, protein is less in breast milk and more in animal milk. Which kind of protein, type of protein? Breast milk is found to have more whey protein, whereas animal milk is found to have more casein protein. Another funda you need to understand, whey is more. That does not mean कि सारा whey है. What it means is the whey component is more compared to casein. Similarly, animal milk has majorly casein protein. Some minor amount of derivatives and minor amounts of whey protein may be present. But predominant protein is whey in breast milk, and in animal milk, it is casein protein. Then DHA, also called as docosahexaenoic acid, it is found in breast milk. It is absent in animal milk. Right? DHA is essential for brain and retina development. Vitamin C is present in breast milk, it is absent in animal milk. That is why scurvy does not happen in breastfed babies. But vitamin K and vitamin D are found to be low in breast milk, and they are found to be not very high but relatively higher in animal milk. Relatively higher. And then we have calcium content, which is low in breast milk, high in animal milk, but calcium to phosphorus ratio, it is 2:1 bracket, ideal in breast milk and variable in animal milk. And so no calcium deficiency occurs in an exclusively breastfed child. Exclusively breastfed child. Sunil, there are 3 color codes used in IMNCI: green, yellow. Just like you have 3 traffic lights: green, yellow, red. IMNCI 3 color codes: green, yellow, pink. Green, child does not need antibiotic, supportive therapy good enough. Yellow, oral antibiotic, give in front of you, follow up after 2 days, but no need to admit. Pink, refer to higher center, child needs admission. Right? That is the funda we follow. So this is a table you can add to your notes. Most of you know it already. Another controversy I'm going to tackle here. Controversial point. A lot of you find different versions in different areas. What is the whey to casein ratio? I'm writing on the side. Whey to casein ratio in breast milk. Whey to casein ratio in breast milk. If the examiner asks you colostrum, it has more whey protein than casein, so ratio will be 80:20. That is 4:1. And if examiner asks mature milk, in a transitional milk, it becomes somewhere around 70:30. But in a mature milk, it becomes 60:40. It becomes 60:40. Anuj Kumar has asked a very good question. What about iron? Iron content is low in breast milk. It is better in animal milk. But in bracket, you would write absorption is better. And so no iron deficiency occurs in exclusively breastfed child. Right? Absolute amount is less, but absorption is better. So no iron deficiency occurs in exclusively breastfed child. Right? So this is the funda. So this whey casein ratio, I'm marking with yellow. please add it to the notes. This is based upon the standard textbook guidelines. Question number 7. Now it's an easy one. We can pick up a bit of speed. All of the following are consistent with Klinefelter syndrome except. You all know what is Klinefelter syndrome. It is a aneuploidy in which there is a genotype of 47XXY. Due to Y chromosome, they are males, but they have additional X chromosome, so they are males with feminine characteristics. So look at the options and give me the answer. All of the following are consistent with Klinefelter syndrome except examiner is asking what is incorrect. So are they tall for age? It is a true statement. There is hyalinization of seminiferous tubules. This is a true statement. Is there hypertrophy of Leydig cells in testes? It is actually a true statement. This hypertrophy occurs because of high gonadotropins. That is FSH and LH are high. Under their effect, they are not functioning, but their size becomes hyperplastic. And low FSH is a false statement. Examiner is asking which is not seen in Klinefelter syndrome. And so answer to your question is D, low FSH. Low FSH, right? Low FSH is the answer. Remember that in Klinefelter syndrome, there are some points you already know. In Klinefelter syndrome, when you do testis biopsy, testicular biopsy, when you do, two things are commonly found. There is hyalinization, also called as destruction of seminiferous tubules, hyalinization of seminiferous tubules, and secondly, there will be hyperplasia of Leydig cells. Because seminiferous tubules are gone, so no sperm production will happen. So although Leydig cells are hyperplastic, still they are non-functional. Only the size is increased. Size bada hai, kaam nahi karta hai. So they are larger in size, but they don't function. It is because they are enlarged only because of the gonadotropins in the patient. And Klinefelter syndrome people tend to have, these patients tend to have hypergonadotropic hypogonadism. Hypergonadotropic hypogonadism. What it means is, in bracket you can write increase FSH, increase LH, and decrease testosterone. Decrease testosterone. There is both hypertrophy and hyperplasia. Both hypertrophy and hyperplasia. Do not apply pathology everywhere. Too much of pathology interferes with clinical learning. Balance is needed. So there is both hypertrophy and hyperplasia. Right? So question number 7, answer is D. Next, question number 8. Which of the following is false regarding HIV in infants? Look at the 4 options and give me the answer. Let us come to this question after we do a quick review of the HIV in infancy guidelines. So let us do a quick review. Many of you might be reading the older guidelines. Please update your guidelines accordingly. Now, any baby, there is a mother. Imagine there is a mother who's HIV positive and she bears a baby. Baby comes into this world. We will call the baby as HIV exposed infant. We don't know whether the baby is actually infected or not. But any baby born to a HIV positive pregnant female is called as a HIV exposed infant. So what are the guidelines for HIV exposed infant in such cases? What are the guidelines in such patients? First of all, the method of initial feeding. Guidelines say exclusive breastfeeding is always the preferred mode of feeding in such patients. So exclusive breastfeeding, also written as EBF, is the preferred mode. If that is not in the option, the second option will be exclusive replacement feeding. Second option will be exclusive replacement feeding. Exclusive replacement feeding, also written as ERF. Exclusive replacement feeding, also written as ERF. This is the first thing, that is method of initial feeding in the patient. Can breast milk transfer HIV? Yes, but the chances are low. Benefit outweighs the risk. And if you give antiretroviral prophylaxis, again, it kind of protects the child. So exclusive breastfeeding is recommended. And these days ARTs are very good. And so you need not give any additional therapy to the child except for prophylaxis. And we assume that the chances of benefit from breast milk is better. It is going to reduce the mortality. So exclusive breastfeeding is recommended. Second is antiretroviral prophylaxis. Remember that all babies who are born to HIV positive mother, it is started in all HIV exposed infants. All HIV exposed infants from day one of life. D1 means from the very first 24 hours of life. Now, what is the antiretroviral prophylaxis that we follow? For low risk infants, we start with oral nevirapine. What is low risk? Low risk for getting HIV infection. So, oral nevirapine is given daily for 6 weeks. But if it is a high risk infant, what is a high risk infant? There are guidelines which define a high risk infant. For example, if the mother, HIV positive mother, was not on ART, so baby will be at high risk for getting HIV infection. So in these patients, you will be giving a combination of nevirapine along with zidovudin. Nevirapine is given once daily, zidovudin is given twice daily. So basically both will be needed daily. And for how much duration you will give? If exclusively breastfed, you will give for 12 weeks. And if exclusively replacement fed, you will give for 6 weeks. When you read from PSM older guidelines, you would find that they are saying 6 months we can give. That 6 month funda is no longer there in the new guidelines, right? You give for 6 weeks or you give for 12 weeks. That 6 month funda is no longer here, right? That duration of ARV prophylaxis, right? Third thing, HIV testing. How are we going to do the testing in the patient? The testing, when to do, what is the time that you will do? It should be done 6 weeks of age or anytime. These are guidelines, so please remember them. लिख लो कहीं पर, write it down somewhere and revise it multiple times before you sit in any competitive exam, ranging from FMG to NEET PG to INI CET. So HIV testing should be done at 6 weeks of age or any time before or after if signs and symptoms appear. If signs or symptoms appear. For example, diarrhea occurs, pneumonia occurs, for any reason, you would do at that moment. How you do it? You don't take whole blood, you check for dried blood spot. What is dried blood spot? It is a technique to collect sample in the patient. So there is a newborn who's HIV exposed. At 6 weeks of age, child comes, clean the sole of foot of the child, puncture the sole of foot with a sterile needle. Capillary blood comes, take on a blotting paper, and when you take on a blotting paper, let it dry for some time and then send to a WHO accredited lab. That method is called as dried blood spot method. Dried blood spot method. And what is the test that we do? The test done. Earlier we used to do DNA PCR. Now we do HIV PCR. For HIV PCR, which checks for total nucleic acid. Remember, we check for TNA. What is TNA? Total nucleic acid. What it means is that you not only check for DNA, you also check for RNA. Remember, HIV is a retrovirus. So it will make DNA from a RNA copy. And then DNA will further form mRNA. So DNA and RNA, both of them are tested. Is it available in our country? Yes. In fact, now this is the only test which is being done. The guidelines say if not available, then you will go for HIV DNA PCR. So remember for your future exam, if both of them are mentioned, total nucleic acid, that is DNA plus RNA, and DNA PCR, what is the better answer? Total nucleic acid, that is DNA and RNA both. But if there is a no such option, then what you will mark? The second best answer will be HIV DNA PCR. Answer depends upon the options given to you. If I am a INICET examiner or a NEET PG examiner, I would be very interested in knowing whether you know this change or not. So it is again a high probability thing to be asked in the exam. And based upon this HIV testing, you will be doing. So there is a complete protocol for that. For details, you can have a look at. I have put up videos also, and that is discussed in my classes as well, right? So this is how we do testing. Remember, antibody-based testing like ELISA is not effective for initial screening because maternal antibodies can cause a false positive test. Now, important thing to add, if now I'm very writing another important point which many people tend to miss. If HIV positive detected in a child, what ART combination to be used? what ART combination to be used. This ART combination is different from that of adults. So it depends upon age of the child. On one side I am writing age, other side I am writing ART combination. So this is a hot topic, and it is overlap between pharmacology and pediatrics. So age, if age of the patient is less than 6 years, you will be using a combination of abacavir with lamivudine with protease inhibitors. They come in a combination of lopinavir ritonavir combination. I'm not writing alternate, they come as a combination. So abacavir, lamivudine and lopinavir ritonavir combination. If age of the patient is between 6 to 10 years, in such patients you will use abacavir plus lamivudine. But what you will add now? You will add dolutegravir in the patient. Dolutegravir is not recommended below 6 years of age, but above 6 years, it can be used. It's a very, very effective agent. And if the age of the patient is more than 10 years, then now tenofovir can be used. Tenofovir cannot be used before 10 years of age. So tenofovir with lamivudine with dolutegravir. It's very important. Add it to the notes. And this is also a new table added in OP Ghai 10th edition. So not only relevant for INI CET, but also relevant for your NEET PG exam. And many of you who have not, I know at least couple of you who have messaged me before the class, you are in final year. So this is surely something going to be asked in your vivas also. So please add it to the notes. Yes, you read pharmacology, you read PSM, but pharma PSM have too many things to remember. So this table will make sure that high yielding thing you don't miss in the actual exam. Right, let's move further. Let's go to question number 9. Now we are into easy thing. Identify the incorrect match for abnormal facies and the corresponding disease. 4 types of facies, 4 types of syndromes or diseases are given. What is your answer? What is your answer? Have a look at the options and give me the answer. Have a look at the options and give me the answer. What is the answer to this question? Bird facies seen in sickle syndrome is correct. Monkey child facies, due to loss of buccal pad of fat, wrinkles will appear like a face of a monkey. That is correct. Chipmunk facies seen in thalassemia. Yes, there is a pinched out nose and there is maxillary hyperplasia that is called as chipmunk facies, and they will have a prominence of these two teeth. Bunny kind of teeth will be appearing. And elfin facies is not a feature of Fragile X, it is a feature of Williams syndrome. And so the incorrect match in this patient, the answer to this question is A, elfin facies in Fragile X. Fragile X syndrome, large head, large ear, large or large testis, but no other major deformity described. So question number 9, the answer is A, elfin facies. These are the 4 abnormal facies. Let us identify them. You can get a MCQ on any of them. So what is the first image showing you? This is what you call as elfin facies. And elfin facies is seen in a patient with Williams syndrome. So this is seen in a patient with Williams syndrome. Look at the second photograph. Can you see the flat nasal bridge, pinched nose, and this part is becoming prominent, and maxillary hyperplasia? This is what you call as chipmunk facies. This is called as chipmunk facies. And this is seen in patients with severe hemolysis, particularly thalassemia. Which thalassemia? Beta thalassemia major. You will see this. Then look at this. There is wrinkles appearing on the face of the child. This is what you call as monkey facies. The face looks like a child of a monkey. Compare it with a monkey's child. You will find a lot of similarity. So monkey facies seen in a patient with marasmus. And look at this child. Can you see microcephaly, alopecia? There is a beaked nose in the child, and also child is having a small jaw which is retractile. So this is what you call as bird facies. And bird facies are typically seen in a patient known as Seckle syndrome. They are seen in a patient known as Seckle syndrome. Seckle syndrome is also known as Harper syndrome. This is not Harper textbook. Harper syndrome, Seckle syndrome. And it is an autosomal recessive condition. Autosomal recessive condition. It tends to show autosomal recessive inheritance. And the gene in these patients is ATR gene present on chromosome 3q. Outcome is poor, but treatment is in these patients is mostly supportive, because there was some question related to Seckle syndrome asked in other exams, not INI CET, but other exams in the recent past. So it is important that at least 3-4 points about Seckle syndrome you need to add to the notes. So these are the abnormal facies, the spotter images which can be asked in the exam. Let us go to question number 10. A 4-week-old male child is found to have hypoglycemia, hyperpigmented scrotum, hyponatremia, and shock like state. External genitalia. See, this is a male child, but external genitalia is like that of a female. Which hormone deficiency can produce such a clinical picture? Which clinical disease, which hormone deficiency can produce such a clinical picture? First, you need to make the diagnosis. How to make the diagnosis? Remember this funda. For questions like this, any child having any child having hypoglycemia with hyperpigmentation, right? That will be the first thing. Hypoglycemia with hyperpigmentation, number one, with either features of mineralocorticoid excess. Mineralocorticoid excess. What is mineralocorticoid excess? Aldosterone excess. They will cause salt retaining crisis, we call it as salt retaining crisis, or mineralocorticoid deficiency. They will be called as salt wasting crisis. Or patient is having any abnormal ambiguous genitalia, male having a female genitalia, female having a virilized genitalia like that of males. So mark it like this: hypoglycemia with hyperpigmentation along with either mineralocorticoid abnormality or genitalia abnormality. If any of them, a child need not have all three. If any two is likely to have CAH, the patient is likely to have CAH. What is CAH? Congenital adrenal hyperplasia. Congenital adrenal hyperplasia is due to deficiency of enzymes involved in adrenal cortical hormone synthesis. And look at the four options. All the four options can produce such a picture. Now, how to approach such a question if you get it in the exam? Look at this handmade chart which I have made. This chart will give you the answer in vast majority of the patients. How? Let's have a look at the question. Suspected CAH patient comes to you. First thing to do, look at the crisis. Either there is mineralocorticoid deficiency or excess. If there is deficiency, we call it as salt wasting crisis. We call it as salt wasting crisis. In these patients, the patient will be having shock, hyponatremia, hyperkalemia, and either it will be 21 hydroxylase deficiency or 3 beta hydroxysteroid dehydrogenase deficiency. If it is salt retaining, it will be 11 beta or 17 alpha hydroxylase deficiency. So when you see the type of crisis, two options will be ruled out. Then you look at the genitalia of the patient. This is something you will have to cram up, you will have to remember. Ambiguous genitalia is always produced by 3 beta. 17 alpha goes opposite to 21 and 11, which tend to go together. Now remember it like this. You need to cram it up. You need to make it 2 or 3 times. I have discussed in my classes also. I have discussed in DocTutorials video lectures also. You make it like this and you will always reach the correct answer. Let us apply this funda to the question. Now this question is having male child. Now this question is having a male child and he's presenting with hypoglycemia, hyperpigmented scrotum, hyponatremia, shock-like state, and abnormal genitalia. So he has CAH. Which type of CAH? Look at the crisis. The patient has salt wasting crisis. So if there is salt wasting crisis, the it can be either 21 hydroxylase deficiency or it can be 3 beta hydroxysteroid deficiency. 11 and 17 cannot be the answer because they will cause hypertension, right? This is a patient with hyponatremia. They will be having hypernatremia. So 21 or 3 is the answer. Now, which one is the better answer? Look at the genitalia. External genitalia appears to be like that of female. So male having female like genitalia, 21 will have a normal genitalia. Have a look here. Male will have normal genitalia in 21. So answer to this question is D, 3 beta hydroxysteroid dehydrogenase deficiency. I will repeat. Listen to me carefully. You can pause this video and listen to it later as well. It will go up on the YouTube channel of DocTutorials. Any child who has uh, three layers are there in the adrenal cortex: zona glomerulosa, fasciculatus, reticularis. They produce three types of hormone: cortisol. Cortisol deficiency will cause hypoglycemia. Mineralocorticoid deficiency or excess will cause either hyponatremia, hypotension, or hypernatremia, hypertension. And third will be sex hormone. If they are normal in a normal child, they may cause precocious puberty, but they will not affect the genitalia. On the other hand, if a male has a female-like genitalia, we call it as ambiguous genitalia. They were called as pseudo-hermaphroditism. So whenever there is hypoglycemia with mineralocorticoid involvement or any abnormal genitalia, we call it as CAH. In CAH, first you look at the crisis. The type of crisis will help to rule out two options. Then you look at the genitalia, and looking at the genitalia, you will reach the correct answer in the question. Right? Apply this rule, try out, practice some questions. In the Q bank of DocTutorials also, we have added similar questions. Try it out and you will find that this is a very, very useful thing. Do let me know later in case you have any difficulty. I will be sharing my details as well. You can always ask me how to approach this kind of question again, right? So question number 10, the answer is D, 3-beta hydroxysteroid dehydrogenase deficiency. Let us move further. Question number 11. Easy one. Infant with recurrent episodes of projectile non-bilious vomiting has recently been diagnosed with congenital hypertrophic pyloric stenosis. Which among the following is or are true? So this is a patient with CHPS. CHPS. Which of the following is or are true? Let us go look at the options one by one. Hyperbilirubinemia is the most common association. Hyperbilirubinemia is the most common association is a true statement. Why? According to Nelson, 25% patients of CHPS have prolonged unconjugated hyperbilirubinemia. This is because of sluggish conjugation process seen in these patients. So they can have prolonged unconjugated hyperbilirubinemia in 25% patients, which slowly improves with time. And these patients are said to have icteropyloric syndrome. Very, very important. What is icteropyloric syndrome? If CHPS has jaundice, we call it as icteropyloric syndrome. It is a potential MCQ point. Please mark it, add it somewhere. Then look at this. So first option is true. Look at the second option. Epigastric mass with visible peristalsis. Yes, there is a olive-shaped epigastric mass with visible peristalsis seen. This is a true statement. Due to repeated vomiting, loss of gastric juice causes alkalosis. So option number 4 is also correct. And loss of chloride will happen. Renin-angiotensin activation will cause sodium retention, leading to sodium becoming normal, but potassium getting lost. So option number 3 is also true. Right? So answer to question number 11, A, B, C, and D, all the 4 are correct. And that is the answer. 1, 2, 3, and 4, that is the correct answer. Right? That is the correct answer. So many of you are answering it correctly. So answer is A, B, C, and D. Anuj, that algorithm will make more sense if you solve MCQ. So my humble suggestion, theory is one thing, MCQ is another thing. You read only theory, selection is doubtful. You read only MCQ, selection is doubtful. You bring both of them together and you are a master of PYQ and PY topics reasonably. Do it for all 19 subjects. You have a strong fighting chance. End of the day, INI CET, very limited seats are there and high negative marking is there. So luck factor will also come into play. Luck is not in your hand, but what is in your hand is your preparation. So don't look at that 1% thing, look at 99% thing which is in your hands, and let us have a fighting chance. Because if luck goes wrong in one exam, it can't go wrong consistently. If not in INI CET, maybe NEET PG. Not in NEET PG, maybe May INI CET, you will get a branch of your choice in a place of your choice, right? So question number 11, answer is A. Question number 12. A patient of sickle cell anemia was started on hydroxyurea to reduce the chances of recurrent painful vaso-occlusive crisis and acute chest syndrome. So hydroxyurea start kiya hai, and he had progressive pancytopenia, due to which you had to stop the drug. Which alternative agent can be considered in the patient? So basically, sickle cell anemia, what are the drugs to use? That is what this question is asking. We'll come to this question. Let us have a look at the of things which have been mentioned. Sickle cell anemia. First thing to understand, the major cause of morbidity and mortality in sickle cell anemia is painful vaso-occlusive crisis. क्या होता है ये? Let me explain. Sickle cell anemia has sickle-shaped RBCs. These RBCs have a tendency to stick to each other, polymerize, and form thrombus in small vessels, small capillaries. Suppose I am a patient of sickle cell anemia. I get dehydration, or I have hypoxia, or I have any illness. So what will happen is the sickled RBCs, they will join together in small capillary and block the arterial circulation. This will cause ischemia of the peripheral circulation, and this will produce features like severe bone pains, dactylitis, that is painful swelling of the digits, painful priapism in a male child, persistent painful penile erection, and gangrene, and they can progress to, sometimes it can cause stroke in the patient as well. Stroke can also occur, TIAs can occur in the patient. So what is the treatment for painful vaso-occlusive crisis? First of all, what is the treatment that you will give? IV fluids will be needed. You will give IV analgesics. Oral analgesics will not work, and you will give oxygen. So basically, supportive therapy is given. No specific drug is available. As you increase hydration, thus, and you give oxygen, the patient tends to come out of the crisis. However, repeated episodes can cause repeated hospitalization and can even cause death. So preventive therapy, 3 drugs are approved for use. First is hydroxyurea. Second is voxelotor. And third is crizanlizumab. Hydroxyurea is used in all children. It is approved for use. It acts by increasing fetal hemoglobin, which inhibits sickling in the patient. We all know that if HbF is there, it will inhibit sickling in the patient, right? But it has a side effect. The side effect of hydroxyurea is bone marrow suppression. So it can cause pancytopenia. So we need to have other agents also available. So we have voxelotor and crizanlizumab. Voxelotor acts by inhibiting inhibiting the HbS polymerization. It inhibits HbS polymerization. And so it reduces the chances of crisis. And what is crizanlizumab? Crizanlizumab is a potential MCQ point. These both are mentioned in OPGHI 10th edition also. OPGHI 10th edition. They were not there in 9th edition. They have been added in 10th edition. So crizanlizumab is a monoclonal antibody directed against P-selectin. You know that there are integrins and selectins. You have read in pathology. So P-selectin is the molecule on vascular endothelium and RBC membrane, which is responsible for sticking of the RBCs together. By using this antibody, the chances of RBC sticking and causing ischemia are reduced. Crizanlizumab is FDA approved in all sickle cell anemia patients daily basis above 16 years of age. But less than 16 years, it is used off-label. Off-label means FDA does not approve it, but generally 10 to 16-year child is requiring a lot of hospitalization. We do use it on a per case-to-case basis. Details you need not go into, who are the patients to identify. They are not going to ask you such fine points, right? So this is crizanlizumab. Also, there is another drug which is not available in India. That drug is called as L-glutamine. L-glutamine by itself does not have a role, but L-glutamine can also added to it. It is an add-on drug which decreases the crisis frequency in sickle cell anemia patients. Add-on drug means when you give L-glutamine supplementation, again, by multiple mechanisms, the RBC polymerization is reduced, right? So this is the therapy, and this is a summary of treatment and prophylaxis. Very important. INI CET 21 or 22, I don't remember exactly. Already voxelotor has been asked in the exam, right? So you can get a fresh question on this time. Go back to the question and now tell me the answer. Look at it and give me the answer. Now, which alternative agent can you consider? Oxycodone. Basically, you have to use oxycodone is a analgesic, but it is not useful in the prevention or the treatment of the patient. So that will not be the answer. Basically, you need to use a alternative drug to hydroxyurea, which will reduce the frequency. Cyclophosphamide has no role. D-glutamine is not used, bracket, L-glutamine is used. And so the answer to this question is B, crizanlizumab, right? Examiner will be smart. He will not say young child. He will write patient, because FDA approved, it is only beyond 16 years of age. Question number 13. It's an easy one. Easy one. Which of the following statements? Don't go anywhere. We'll finish off in 15 to 20 minutes. And then I will summarize the key topics you must not miss for the upcoming exam, right? So which of the following statements are false regarding protein energy malnutrition? There are three parameters: weight for age, weight for height, height for age. So best parameter for acute malnutrition, it is weight for height. Best parameter for chronic malnutrition, it is height for age. Affected in both, but not sensitive, it is weight for age. Keeping this in mind, now have a look. Which of the following are false? Weight for age is more sensitive indicator for acute malnutrition than weight for height. It is a false statement, right? Weight for age is affected in both acute and chronic, but it is not sensitive for any of them. Remember it like this. Weight for age jo hota hai, this is jack of all trades, master of none. Tries to say, I know everything, I am affected in everything, but it is not a master or sensitive indicator in any of them, right? So jack of all trades, master of none. This is weight for age. So option number 1 is false. Height for age indicates long-term nutritional status. Yes, chronic malnutrition, it is an indicator. So this is a true statement. Baggy pants appearance may be seen in kwashiorkor. It is false. Baggy pants appearance is a feature of marasmus due to fat loss. And edema with mental changes are hallmark findings in kwashiorkor. This is also a true statement. Now, examiner is asking false. So you have option number 1 and option number 3. So which is the option here? A is your correct answer. So answer to this question, question number 13, the answer is A, 1 and 3. Let us move to question number 14. All of the following drugs. Now, there is a reason I have put up this question, because there is an update on this in the recent guidelines and textbooks. All of the following drugs have been found effective in the medical management of PDA except patent ductal arteriosus. It is kept open by prostaglandin. So giving prostaglandin inhibitors can have resolution or closure of the PDA. Remember, for medical closure of PDA, three drugs are generally used. What are these three drugs? First is indomethacin. Indomethacin was the earliest drug to be used. Second is ibuprofen. Ibuprofen is the best agent to be used. And third is acetaminophen, also called as paracetamol. And that is a upcoming agent, right? No role of any fourth drug in the management of VDA, according to all standard guidelines. Diclofenac, naproxen, mefenamic acid do not have a role. They are non-steroidal anti-inflammatory drugs, but they are not efficacious in a patient of PDA. And so the answer to this question by exclusion is C. Naproxen is not useful in such patients. Now, regarding medical closure of PDA, I want to share some information with you. Please update your notes. Nelson and Ames protocol, recent changes, both of them 2024 changes. So this is an update discussion also I'm having with you. Nelson 22nd edition release हुआ इस साल June 24 में. What does it say? It says, read Nelson. This is the snapshot from Nelson. Meta-analysis showed higher dose of oral ibuprofen using this dose given for this is, so oral ibuprofen is superior in closing the PDA compared to indomethacin or the older ibuprofen regimens. So they say this regime should be followed and it has less side effects as well. So which is a preferred agent? If both are mentioned, ibuprofen is the better answer. But if they mention only one, then obviously that you can safely mark. Ames protocol says paracetamol has closure rate similar to other agents but has lesser side effect. But further studies are needed before it can be recommended. So not yet recommended. Why? Possible autism association. मैं नहीं कह रहा हूं, एम्स प्रोटोकॉल कह रहा है. autism association, you will not take a risk till you have sufficient data. And brain damage has been shown in the lab studies done on mice as well. So what do we give? Ibuprofen. If not possible, indomethacin. None of the two are, a patient is hypersensitive, allergic, anaphylaxis is there, then there is no other option, then you have to go for paracetamol. And generally what we do is, first trial we give ibuprofen. If that fails, we can consider giving the second trial as paracetamol. This is mentioned in Nelson also. Remember this entire conversation which we have done, listen to it and add to your notes, whether it is your pharma notes or your pediatric notes or your medicine notes. This is latest, this is important, right? Question number 15. A child is suspected to have inherited tubular disorder. So you have Bartter, Gitelman, Liddle syndrome, etc. All of the following factors can be used to distinguish Bartter syndrome from Gitelman syndrome, except how you are going to differentiate between them. Again, let us take the help of a flow chart. Then we come back to this topic. So when will you suspect tubular disorder in a child? There will be vomiting, polyuria, polydipsia. There will be vomiting, polyuria, polydipsia, and failure to thrive in the patient, along with ABG abnormalities. But you need to rule out diabetes mellitus and diabetes insipidus, right? In such patients, you will suspect a tubular disorder. First step to do is look at arterial pH. This is a one-liner MCQ from old NEET PG question also. What is the first test to perform in a suspected case of tubular disorder of the kidneys? It will be checking for, do a ABG to check for arterial pH. Many people will be marking urine examination or urine electrolyte. No, blood test needs to be done in such suspected patient. So it's a one-liner. I put a Q. अगर arterial pH में आपको, if you find metabolic acidosis, then you will suspect RTA, renal tubular acidosis, or you will suspect Gordon syndrome and similar rare disorders, and you will evaluate for them. But if you find metabolic alkalosis, there will be two possibilities in the patient. Either it is Bartter syndrome, Gitelman syndrome, or it is Liddle syndrome. So metabolic alkalosis with hypertension, the answer will be Liddle syndrome. If there is normal BP, then you look further. In case patient is having a facial dysmorphism, hypercalciuria, increased urine calcium excretion, normal magnesium level, Bartter syndrome is the answer. If there is no dysmorphism, calcium urine excretion is less than normal, and magnesium levels are low in the blood, we call it as Gitelman syndrome. And Gitelman syndrome will be milder and it will have late presentation. In Bartter syndrome, ibuprofen is effective. Ibuprofen is used. In Gitelman syndrome, there is no role of ibuprofen. Why? Ibuprofen क्या है? मैंने अभी तो बताया. I just told you ibuprofen is a prostaglandin inhibitor, because in Bartter syndrome there is prostaglandin E2 levels are raised in Bartter syndrome, and so you give ibuprofen to reduce them, whereas here the prostaglandin E2 levels are normal. So no role of ibuprofen. So no role of ibuprofen in such patients. No role of ibuprofen in such patients. So with this in mind, let us go back to the question. There are two ways of answering questions like this. First, you know physiology, impossible thing, but still you know physiology. Then you apply all the fundas of those channels and everything and those transporters, and then reach the correct answer. Or you take the help of a flowchart like this. This is a smart way. So let us see if you can solve question or not. Look at the question now. Which of Bartter syndrome can be distinguished from Gitelman syndrome by all of the following except serum magnesium level can be used. One has high magnesium, one has low magnesium. Urine calcium excretion can be used. One has high, one has low. Serum PGE2 level, yes, serum PGE2 is high in Bartter. That is why we are using ibuprofen. It is low or low to normal in Gitelman. That is why ibuprofen not effective. Presence of metabolic alkalosis cannot be used because both have alkalosis. Both have metabolic alkalosis. And when it is present in both, how would you distinguish them? And so answer to this question is B. Presence of metabolic alkalosis. Presence of metabolic alkalosis. Right? Indomethacin. Right, sorry. Ibuprofen or indomethacin. Indomethacin. Remember, in these patients, indomethacin is preferred. Indomethacin is preferred. You can write like this. Indomethacin is preferred. And you can put a star and write somewhere Additional point also, in PDA, you can write like this. In PDA, ibuprofen is preferred over indomethacin. But in gout as well as Bartter syndrome, indomethacin is preferred over ibuprofen. Please write it somewhere. You can add it to your notes, right? Right? Let's move to the last 5 questions. We're on to the last 5 questions. Question number 16. A child presents with dark brown colored urine since 3 days. Whenever you have a question like this, evaluate what the examiner is going to ask. Dark brown colored urine or a cola colored urine, the possibility is likely, patient is likely having gross hematuria. So patient is likely having gross hematuria, right? Next, move further. Since 3 days with mild edema of the face and legs with 2 plus proteinuria. So proteinuria with facial edema. So it is a renal disorder we are thinking of. BP is 130/90. In a young child, it will be possibly hypertension. RBC cast are present. RBC cast means glomerular origin of hematuria. Glomerular hematuria typically seen in acute nephritic syndrome. So this will be seen in patients with acute nephritic syndrome. Acute nephritic syndrome. And serum cholesterol is 186 milligram per deciliter, which is found to be relatively normal. Which of the following does not present with this finding? Basically, they are asking you which of these conditions will have mild to moderate proteinuria, normal cholesterol, and presence of RBC cast. And the answer to this question, if you see carefully, the answer is B, minimal change disease, because these patients have proteinuria, which is massive, that is 3 plus or 4 plus, not 2 plus urine protein. They have no hematuria, so no RBC cast will be there, and no hypertension. And these patients, mostly, they are found to have increased serum cholesterol as well. And so, which is the odd one out here? It is minimal change disease, which is the odd one out. And so, this is the answer. This question is a modified repeat of AIMS MCQ 2019 before COVID came and INI CET exam became a reality. I hope you know that during the COVID time, INI CET came into being. All the exams were merged. Before that, AIMS, PGI, JIPMER, NIMHANS, they all used to have their own individual exams, right? So, question number 16, answer is B. Let us remember a key word here. Whenever an MCQ says, whenever a question says, now making a handmade small chart here, whenever a question says there is a patient having, there is a child, there is a patient having facial edema or hematuria or proteinuria, in such patients you should suspect a glomerular disorder. You will suspect a glomerular disorder, right? Now, first thing to do is check urine protein. Check urine protein. When you check urine protein, there will be two possibilities. Either urine protein is 3 plus or 4 plus, or it is 1 plus or 2 plus. If it is 3 plus plus 4 plus, it is likely to be nephrotic syndrome in the patient. Nephrotic syndrome. And if it is 1 plus or 2 plus, it is likely to be acute nephritic syndrome. Acute nephritic syndrome. Nephrotic syndrome is of two types, primary and secondary. Primary, most of them are minimal change disease. And these are the patients who will be having no hypertension, no hematuria, and they will show good response to steroids. Whereas in secondary, there is a variable presentation. Hypertension can be there, hematuria can be there, response to steroids will be variable. Acute nephritic syndrome will have hematuria, and when they say hematuria, there will be RBC cast which will be present. They will have proteinuria, they will have oliguria and hypertension. And if examiner says it is precipitated by infection, precipitated by infection. And 1 to 5 days later onset occurs, the likely diagnosis will be IgA nephropathy. And if examiner says 1 to 3 weeks later, पहले infection हुआ, 1 to 3 weeks later there was onset of acute nephritic syndrome, post streptococcal glomerulonephritis will be the answer. So this again is a very, very useful clue, useful flow chart. This will be a common explanation of many of your past MCQ points as well. So agar examiner bole, if examiner says that a child had a sore throat and 5 days later there is RBC cast, proteinuria, hematuria, hypertension, oliguria, what is the diagnosis? IgA nephropathy. If it says 2 weeks later it happens, the answer will be post streptococcal. And if examiner says no hematuria, no hypertension, massive proteinuria happening, and good response to steroid was seen, answer will be minimal change disease. It will be a type of the common type of nephrotic syndrome, right? So nephrotic, this is nephrotic syndrome. If this is not nephrotic, this question is not nephrotic, this is acute nephritic syndrome, right? Because nephrotic will always have massive proteinuria. If there is no massive proteinuria, it cannot be nephrotic syndrome. Remember this funda. Okay. Question number 17. Duration of steroid therapy given before deciding steroid-resistant nephrotic syndrome in children is, it's a one-liner question. It is 6 weeks now, and it is a OPGHI update as well. So you can write in bracket OPGHI 10th edition update. That if there is no response or no remission, bracket mein we call it as remission, despite 6 weeks of daily full dose steroids, that is prednisolone, you call it as steroid resistant nephrotic syndrome. What do you do in steroid resistant nephrotic syndrome? First, do renal biopsy. What is the drug of choice in SRNS? It will be calcineurin inhibitors. You will be starting with calcineurin inhibitors. And calcineurin inhibitor tacrolimus by cyclosporin, right? So add it to the notes. It is an old MCQ whose answer now has changed. Question number 18, last 3 questions we are on to now. Question number 18, 5-year-old child presents to emergency with altered sensorium, polyuria, polydipsia, and acute abdominal pain. He is having hyperglycemia. I'm highlighting with a different color. So there is high blood glucose, more than 200 milligram per deciliter. Ketosis is present and acidosis is present. So patient is having diabetic ketoacidosis. So the patient is having diabetic ketoacidosis. Polyuria, polydipsia, abdominal pain, altered sensorium, along with all the 3 present in the patient. This is diabetic ketoacidosis. Which among the following is the first step in the management of the patient? You give me the answer. What is the first step in the management? Tell me. Before I do a quick summary of the key points. There was a question on this asked just 1 year back in NEET also. It was a controversial and tough question. So I will write 7 or 8 points, very useful for your quick review. I know you all have to do other stuff also, but trust me, 10 minutes and we'll finish off the session. And we have covered everything we could in the limited time that we have. So what is the answer? What is the answer to this question? Give me the answer. Which is the first step in the management of this patient? Absolutely right. I'm really happy most of you are answering it correctly. Start volume replacement using normal saline. So what is it about DKA that you need to know? So I'm giving the heading short review of DKA. DKA stands for diabetic ketoacidosis. Diabetic ketoacidosis. It is most common, more seen in type 1 diabetes mellitus than type 2 diabetes mellitus. It can occur in type 2 also, but more commonly seen in type 1 diabetes mellitus. Diabetic ketoacidosis, what is the definition? All 3 should be present. So it is a biochemical diagnosis. All the 3 should be present. What 3 should be present? First of all, patient should be having blood glucose more than 200 milligram per deciliter. So hyperglycemia should be there. Second, metabolic acidosis should be there. How do you say metabolic acidosis? Blood pH should be less than 7.3 or bicarbonate, serum bicarbonate should be less than 15 millimoles per liter. And third, there should be ketosis in the present. Ketone bodies should be there, either ketonemia or 2 plus ketonuria. Out of them, which is more sensitive? Ketonemia, presence of ketone bodies in the blood, but it is not easily available. So you can do ketonuria also. If all the three are present, it is diabetic ketoacidosis. So what is the treatment that you're going to do? First, ABC. What is ABC? Airway, breathing, circulation, like you do in any emergency. Then you start with the definite therapy. First hour of therapy. First hour of therapy, the therapy of choice is fluid management. And so they are giving IV fluids in these patients. Most of these patients are dehydrated, and it is seen that giving fluids not only restores tissue perfusion and saves life, reduces mortality, it also causes mild decrease in blood glucose by itself, right? So IV fluids are the first line therapy. We give normal saline in the patient. So normal saline is the type of fluid that is used. How much amount to use is your INI CET 2023 MCQ. If patient is having mild to moderate dehydration, if the patient is having mild to moderate dehydration, you will use normal saline 10 ml per kg over 30 minutes. If it is severe dehydration or severe decay, examiner will tell you about it. Then you use normal saline 20 ml per kg to be given over 20 minutes. So fluid to dena hi dena hai, right? And there will be no such category as no dehydration in decay. Decay patient is having dehydration, right? And then if the patient is presenting with shock, normal saline 20 ml per kg bolus needs to be given. Bolus means rapid push. And after giving these fluids, you will do two things. You will shift to maintenance fluid, shift to maintenance fluids, and you will do the second hour onwards insulin therapy. Now you will start IV insulin infusion. IV insulin infusion. No bolus should be given. That is where the guidelines differ. In adults, Harrison 22nd edition says bolus can be given, followed by infusion. Right? Read Harrison. Harrison says bolus can be given, followed by infusion. But in children and also in real practice, in adolescent people also, we generally do not give bolus. Bolus increases the mortality by causing cerebral edema. So start IV insulin infusion 0.05 to zero point 0.1 unit per kg per hour. Generally, we start with the lower dose and gradually increase. Any patient, anytime, if if hypoglycemia occurs. Sunil is asking, is CO2 less than 15 a criteria? Yes, but how would you check CO2? You cannot check CO2. You will check for bicarbonate. ABG does not tell you CO2 amount. It tells you the partial pressure of CO2, and that is why bicarbonate is the one that we check. So anytime if you find that the patient develops hypoglycemia or blood glucose goes below 250, do not stop insulin infusion. Do not reduce the insulin infusion. Add 5% dextrose to it. And this is a very important point on which MCQ can be asked. You started with insulin infusion. After 1 hour, now blood glucose is falling dramatically. Would you reduce insulin? No, because if you stop insulin, the acidosis will not improve, right? So you will continue insulin, but you will add 5% dextrose to the maintenance fluid. You will add it to maintenance fluid. And that is the thing that we do in these patients. And remember, potassium needs to be added, but potassium need not be given initially. Only when there is serious ECG changes, you can add potassium initially. Potassium correction can be done. Otherwise, you can add potassium to the maintenance fluids as well. And remember, giving bicarbonate treatment or insulin bolus, they both can cause cerebral edema, and so they are contraindicated. They are contraindicated. Cerebral edema is the most common cause of death in decay. Remember, the most common cause of death in decay is cerebral edema. ये अपने आप भी one-liner question है. Also in medicine, not only in pediatrics, also in medicine, it is a one-liner question, right? So whatever I've written here, you might think ये तो बहुत superficial है. This is not superficial. This is where MCQs are being asked. Because maximum mortality happens, maximum deaths happen in the first 3 to 4 hours of management of decay. If you manage that 1 to 4 hours well, patient's life will be saved. You understand? And many of you, tomorrow when you become residents in medicine or pediatrics, you will be managing it. You will be managing it. So examiner wants you to know before you start managing the patient. At least theoretically, you should know. So answer to question number 18, D. Start insulin infusion will be done after fluids. Option number B, insulin bolus never given. Sodium bicarbonate never given. Insulin infusion not given in the first step. Always give fluid replacement, right? Question number 19, last two questions, then we finish off. As per 2023 update of National Immunization Schedule, which of the following vaccines has been introduced as additional dose at 9 to 12 months of age? What is your answer? What is your answer? Which vaccine has been introduced as additional dose at 9 to 12 months of age? What is your answer? It's an easy one. Waiting for your answer. Yes, the answer to this question is D, that is fractional IPV. What is the update? What is the update? I'm giving the heading. National Immunization Schedule updates. There are two important updates that you should know. First update, that third dose of fractional IPV has been introduced. It has been introduced at 9 to 12 months of age. At 9 to 12 months of age. It is not a booster, it is the third dose of the primary vaccination which has been added at 9 to 12 months of age. Sunil, potassium does not get auto-corrected on insulin. In fact, on giving insulin, hypokalemia can happen. Remember, insulin causes decreased inward movement of the potassium from the blood. So you always need to add potassium in the maintenance fluid, right? Hypokalemia will actually sometimes get worsened. So potassium needs to be added after first hour. You will give insulin, you will give potassium in the first hour only if there is ECG changes at presentation. Otherwise, you will not give. You will add it later after first hour. With insulin, you will add. So first update, third dose of fractional IPV has been introduced at 9 to 12 months of age. And second update, now we are using Genvac vaccine. What is Genvac vaccine? This is the killed, that is inactivated Japanese encephalitis vaccine. It has a strain called as Kolar strain, also called as 82156 XY strain, which has replaced the Chinese made live attenuated SA 1414-2 strain. So India is now Atmanirbhar Bharat when it comes to Japanese encephalitis vaccines. And another use for this is we are not only using our indigenous strain, this vaccine also is now included in open vial policy. Pehle open vial policy could not be applied to Chinese vaccine because it was a reconstituted vaccine. But now multi-dose vial vaccines are coming, and from a single thing you can give multiple doses. So this will change the answer of your past MCQ points as well. Dr. Rajsi, our PSM faculty, our excellent PSM faculty, ma'am will be talking about it in more details, but add these 2 points to your notes. Add these 2 points to the notes. Remember that Kolar strain. Kolar is a place in Karnataka from where this strain was isolated from a man. Have you seen that movie KGF? KGF not only gave us Rocky Bhai, KGF also gave us our own indigenous vaccine strain for Japanese encephalitis, right? So next time when you see KGF or you hear that ringtone, Nanna ni nare nare nare, you will always think of Japanese encephalitis. It's a potential MCQ point, right? Genvac vaccine. So add it to the notes. Let's move further. Last question, question number 20. And then I write all the key points, the topics you must not miss in the last month before the exam. Which among the following is a contraindication to use phototherapy in neonatal jaundice? There is a child. He has neonatal jaundice, unconjugated hyperbilirubinemia. You started therapy, child became worsened, even died. What was the underlying condition? Presence of porphyrias. There is a porphyria called as CEP. What is CEP? Congenital erythropoietic porphyria. It is an autosomal recessive type of rare porphyria in which there is a deficiency of uroporphyrinogen 3 synthase deficiency. And in these patients, if phototherapy is given, it can cause a severe vesicobullous rash in the patient. That can cause serious mortality in the child. So in these patients, phototherapy is contraindicated. If jaundice happens, you have to do only exchange transfusion in the patient. Also remember that presence of conjugated hyperbilirubinemia is not a contraindication, even if it causes bronze baby syndrome. I hope you have read about bronze baby syndrome. When you give phototherapy and there is conjugated jaundice, some skin discoloration can produce due to porphyrin bronze colored pigments. But these pigments are self-limited and it is a non-toxic condition. In a few weeks, normal skin color comes back. So presence of conjugated hyperbilirubinemia is not a contraindication. Breastfeeding is not a contraindication. And lethargy, poor feeding, that is a sign of encephalopathy. You have to treat the patient. Obviously, exchange transfusion will be more effective, but phototherapy can be used till blood is available for the child. So answer to this question is B. Add this point to your notes. This is the only important thing which is missing in many good guidebooks and online material. And this is something, again, I'll be honest, in my video also on DocTutorials, this point I have not discussed. But depending upon, because we are targeting INICET, so you need to have that edge in high yielding topics. And so before I finish off this session, have a look at the last few papers in the exam. PYQs of INICET 20 to 24 you have to do thoroughly. Any topic repeated more than 2 times or more is a previous year topic you have to do in details from your notes. Third thing, there are some topics from where questions are consistently asked in INICET. Milestones, nutritional indices, febrile seizures, nephrotic versus nephritic, vaccines or vaccination, Hanoch-Schönlein purpura and Kawasaki disease, IMNCI guidelines of pneumonia and diarrhea, severe acute malnutrition, sickle cell anemia. Sickle cell anemia, you might, pediatric epilepsies like West syndrome, absence seizures, those kind of topic, neurocutaneous syndromes. Neurocutaneous syndromes. Am I missing something? Yes, I'm missing celiac disease. Celiac disease. And finally, you have the overlap topic with ENT. Rajiv Dhawan sir has already taken your class. So croup versus acute epiglottitis. Croup versus acute epiglottitis. Must not miss. Why? They are often asked. They are often asked in INICET exam. So must not miss for revision from your notes before you sit in the exam. Yes, pediatrics is scoring, but at the same time in pediatrics, and one thing I again missed, neonatal resuscitation. Do not miss neonatal resuscitation. See, there will always be an odd question, but it is INICET. You're not supposed to know everything. Even topper does not get 70, more than 75% score. So 25% you can afford not to know. But pediatrics is a high scoring area, and you there, except for 1 or 2 questions, if you have not read the topic or a fact-based thing, leave it. Remaining 10 to 15 questions which will be there, ranging upon the weightage of the subject, at least 80% are easily solvable. Right? So give some attention to the child, and I hope all of you benefit from it. I'll not extend the session anymore. I hope all of you benefit from it and listen to the session again in 2x speed before you sit in the exam, once before the exam. Add the relevant points to your existing notes, and trust me, INICET exam is doable. It is doable, right? People who crack it, they are smart people, they are hardworking people, they have a bit of luck, but at the same time, they are not exceptionally so high IQ people. Even normal people can get into central institutes if you are willing to work a bit hard and a bit smart. I have been to a central institute, so I know that entering is tough, but again, it is not impossible. So believe in yourself, and still time is there. Do effective revision and don't miss the next session. The next session, again, excellent discussions will be there for you, and all these sessions are going to be immensely beneficial for all of you. So all the very best for the exam, and please let me know in case you have any queries. You can follow me on Instagram, and you can always uh, ask me in more details. I'm very fond of making flowcharts because that is how my mind works in the clinical setting as well. So in case you are having any issue on any of the topic, please let me know on the comments or in the uh, DM on the Instagram, and I will be there to help you out. So on behalf of DocTutorials team, this is a endeavor for all of you to do well, and don't miss DocTutorials upcoming videos, upcoming sessions. God bless everyone. Good night, everyone. Bishkek, I'm coming in November, so don't worry. I'm coming there in November. We can stop the session.